Thank you so much for the patience. I think we are ready to start today's session. Those who have joined us on YouTube, TikTok, and I can see on Zoom, people are joining. Hope you, during the session, ensure you keep your mic muted. And also remember that we are going to have Q&A session, that is question and answer session at the end of the presentation. Thank you. I hope you enjoy today's session.
All right, ladies and gentlemen, I believe you are doing okay. Thank you for joining in. I think we should begin because we don't have any more time. We've given an allowance of close to 30 minutes so that those that were still having challenges and issues to join, they can join. We are a good number, 15 maybe. Those are the ones that intended to be in this meeting. But still there's room. If there's anybody who would want to join, let them join. Our technical team will be there to admit everybody and anybody who would wish to join. Well, I want to thank all of you, and I want to believe that my network is stable. You're able to hear me well. And as we always do, just to be sure, right, just to be sure, I would like you to confirm in the chat box, just hit in the chat box if you're able to hear me well, if you're able to hear me clear, and if you're able to see my presentation. All right. Yeah, and remember, this presentation is also live on YouTube and TikTok, so we have quite a number that are following from TikTok, YouTube, and all other our social media platforms. So please let me know, those that are here, if you're able to hear me well. Just type in the chat box. Let's confirm. Yeah. Let me know. I will appreciate if you're able to hear me well so that I'm not speaking to myself. Oh, great. Thanks, Victor. You're saying hearing is clear. Okay, thanks, Hadija. Is it Hadija or Khadija? Okay, thanks, Ali. All right, Doreen, confirming you can hear well. Okay, Ugoma Eze, everything is okay. I believe this is our brother or sister from Nigeria. Fine, so I think with those few confirmations, I can largely say that we are good to go. Well, I'll start by introducing myself because we could be having, I think most of us are new here. And therefore it will only be in order that I get to introduce myself. My name is Thomas Chacha Nyamuhanga. I am a nurse by profession, and this is one of the most enjoyable profession that I have ever dreamed of. I never regret being a nurse, and I don't think I will ever regret for being one. I've been in the nursing profession for quite some time now. Have been in the field of academia. I've trained a number of students back home in Kenya, and I take pride in some of the achievements that I've had, because I've trained very many students have passed under my hands. Right now, I'm privileged to be practicing my nursing career in the United States. So right now, this lesson is being conducted from right away in the United States. So feel most welcome. If you're a nurse, you have ambitions to be a nurse to practice in the US, a nurse to practice in Canada, to practice in Australia. This is the pathway. Nclex. So today, I don't want to go into more details. Our lesson is going to be a very brief lesson. I just want us to have a quick review on what we call fetal heart tones or fetal heart rate, interpretation, and how to monitor and interventions. Okay. One thing that you must know is that Nclex is just a dreaded exam. Nclex is not complicated. Nclex is not difficult. In fact, by the end of this presentation, you realize that Nclex is very easy. I have put in here questions that are Nclex-like questions, and some of them are real Nclex questions, just to see how the questions can be so easy, okay? So I want to tell you, if you're there and maybe you have heard these stories that Nclex is a very difficult exam, I think it's just overrated and dreaded for no good reason. But here in Apply International, we tend to streamline and simplify things and make it possible so that you're not just afraid for nothing. So those that have been attending my classes, I have always said that Nclex is a safety exam. It's not interested with your pathophysiology. It's not interested with your anatomy and physiology as such. Nclex just wants to establish one thing. Are you a safe nurse? Are you able to identify a potential problem, a potential complication in a patient and prevent a complication from happening? That's what Nclex is all about. It's not about giving medication. Even in that giving medication, are you able to identify a potential problem and prevent it? So it's all about safety, and all the questions, they just center around safety. Yeah, that's what Nclex is looking for. And therefore, if you're a nurse, you're practicing even back home where you are in your home country, always try to ask yourself this question: am I a safe nurse? Because that is what Nclex is all about, okay? Now, this is what we're going to do today. We're going to look at the most important fetal heart strips and how to interpret them and how to put that into real context and answer questions. Of course, in Apply International, we don't teach nurses. Nurses are already taught. They are nurses. They have graduated. They are practicing. Yeah. So we are not teaching you what is anatomy. We are not teaching you what's pharmacology. No. We just want, it's more of a review and a discussion. And we measure our argument mostly on the questions, because what we want to invest in is how to answer the questions. Nclex is a very easy exam, only that it has its own way of answering questions. It has its own design. It wants the questions answered in a specific way. So that is what we are teaching our clients. We call them the question answering strategies. Yeah, so we will unpack these strategies to tell you how to answer the question, even if you've never heard of that condition that is being spoken about. You can maneuver through the strategies and still land in the answer, correct answer, okay? Yeah, so maternity nursing is one of the key components in Nclex. It falls under what we call HPM, health promotion and maintenance. That is a key thematic area. Remember, Nclex is divided into 4 key areas. We have number 1, we call it physiological integrity. Physiological integrity, just in simpler terms, is what we're calling medico-surgical nursing. That's what we call physiological intake. So there we have medico-surgical conditions and pharmacology. Number 2 is psychosocial integrity. Now, psychosocial integrity is majorly psychiatric nursing and mental health. That's area number 2. Area number 3 is what we're calling HPM, health promotion and maintenance. Now, this is where maternity nursing and the newborn care falls, okay? HPM, health promotion and maintenance. So you can see just from that word, when we're talking about maternity nursing, when we're talking about newborn care, it's about health promotion and maintenance. And then the third one is called safe and secure patient care environment, called SECE, S-E-C-E, safe and secure environment and safe and secure patient care environment, okay? So those are the 4 areas that are covered in Nclex, and they cover everything. So maternity nursing is just but a portion in the HPM, okay? Now, today, I want us to focus on the fetal heart monitoring and how to interpret them. I'm sure you must have heard these terms, acceleration, deceleration. So what is that? What is it? Okay. And I'll want us to identify which is the normal and which is the abnormal. So let's start with the first one. We call it acceleration. You know what is acceleration? To accelerate, like when you're driving and you want maybe to join the highway, you have to accelerate, okay? So it means to increase. So when we're talking about fetal heart tones or fetal heart rates, accelerations are good. I mean, imagine like, I just want you to take a little example. You're driving, you're from a feeder road and you want to join the highway. So what are we supposed to do? You're supposed to accelerate. So when you join the busy highway, with that acceleration, you are automatically a good driver. Your vehicle is good. Everything is good. Your technique is good, okay? That's what it means. So even here, what acceleration means is that despite the manipulation in the fetal environment, talk about contractions, talk about fetal movements, we find the fetal heart rate accelerating to keep up with the pressure. How good is that? Okay, that's what it means. When we literally could expect that the fetal heart rate will drop. Now, in this case, when the pressure increases, when the contractions come in strong, when the fetus moves, the heart rate accelerates. Why does it accelerate? To keep up with that pressure, okay? Which is a good thing. So it means that everything is okay. The heart is good, is able to withstand pressure, okay? So that's what we call acceleration. So that was just in a layman's explanation. Now let's see what happens here. It occurs when the fetal heart rate accelerates from its baseline level by at least 15 beats. So check the rule of 15. The rule of 15, we're talking about the rule of 15. So it accelerates by at least 15 beats per minute and is sustained for at least 15 seconds, that acceleration, okay? And I hope you know the baseline, the normal fetal heart rate is always 120 to 160, okay? So when it accelerates from the baseline, whichever baseline was, if it was 130, if it was 135, whatever it was, okay? Now, these changes, they are very reassuring. You can say they are reassuring that even in the wake of pressure and those other, issues that are impacting the fetus, the fetal heart rate is able to pick up and keep up with that pressure. How reassuring is that? Very reassuring. So it means the baby is getting enough oxygen, the baby is okay, everything is good, and therefore we say that everything is okay and no intervention is required. In fact, we should just sit and relax and be happy because the heart and everything, the baby and oxygen, everything is okay. Yeah. So accelerations are okay, right? You don't need to intervene. You just do what? You just document and continue monitoring. Okay. Now. Where is happened? Yeah. So you just document and continue monitor. On Nclex, when anything is document and continue monitoring, it means that it is normal. You don't need to do anything. Just document and continue to monitor. Okay. Now, let's talk about now. We want to take it a notch higher. Now, call it early deceleration. Early decelerations. Now, to decelerate is to reduce. To decelerate is to reduce. Okay. So look at these. Look at these. The picture that I have here. On top is the fetal heart rate, and the amplitudes you're seeing on the bottom face is the maternal contractions. So here we are comparing how the fetal heart rate behaves when the mother goes into contractions. When there is a contraction, how does the fetal heart rate behave? Now, let me bring it home. We know very well for sure that during labor, anytime there is maternal contraction, there is always reduced blood supply and oxygen supply to the fetus. That is for sure, no doubt, okay? And therefore, we will expect that, yes, the heart rate can drop just a bit. So it's not always a must that it has to accelerate. When we say that acceleration is okay, but sometimes we expect it is just expected because with every contraction, it cuts off blood supply. So we expect also that the fetal heart rate is likely to go down, and that's what we call deceleration. Now, when we talk about the term early deceleration, this is how we can interpret it. Look at the maternal contraction and the fetal heart rate. So you can see they are behaving
Sorry for that. I think the tutors left the meeting. I think he's joining in a few.
I'm sorry about that, guys. I don't know what happened. Anyway, back here. I don't know what happened. I think it was a technical hitch. And so we're talking about early deceleration. So I want you to see the difference here. We're going to make a comparison and with some other strips and see. So for early deceleration, remember what is affecting here, what is the determinant is the maternal contraction. So I want you to see when the maternal contraction we are having here, when the maternal contraction begins, you can see right away when it begins, the fetal heart rate also begins to drop almost at the same time. So you can see it mirrors, it's like a mirror. The moment the maternal contractions begins to pick up, the fetal heart rate immediately begins to drop. When the maternal contraction is at its highest peak, the fetal drop is also at its lowest, okay? And like that, like, so it's like a mirror. It's like a mirror. So see the memory trick here. The baby's heart rate mirrors the mother's contraction. That's what we call early deceleration. In other words, the fetal heart rate decelerates early. The deceleration comes in early as the maternal contractions set in, okay? So it's some kind of do me, I do you. Some kind of do me, I do you. That's what happens here, right? Yes, that as the maternal contraction begins to pick up, now the fetal heart rate decelerates, okay? Now, compare that with this one. This is what we call late deceleration. So I want you to see these arrows here. Now, in late deceleration, you see the maternal contraction peaks, goes and reaches maximum, and when it is almost over, it is when now the fetal heart rate comes in late. That's why it is called late deceleration. The fetal heart rate decelerates way after the maternal contraction. So that's why it is called late. Okay. I mean, it's pretty easy. That's how you can differentiate that. Early deceleration, yes, the fetal heart rate will decelerate at the same time when we are having the maternal contraction. They begin at the same time, they end at the same time, okay? But late deceleration, the fetal heart rate is late. Remember the determinant here is the maternal contraction. So we don't have any problem with the maternal contraction. It is the maternal contraction that affects or determines how the fetal heart rate is gonna behave, okay? So this is the late deceleration. So I want you to see this comparison here. Now, is early deceleration bad? Early deceleration is good. I told you that when we have a maternal contraction, yes, we expect that every contraction simply means it cuts blood supply to the fetus. Anytime you're having, that is why you cannot take fetal heart rate, ideally, when the mother is at the peak of a contraction, okay? When you're monitoring using a fetoscope, because it cuts blood supply. So early deceleration, in simple terms, to make it easy, what happens here? It means that when there is a contraction, the fetal head is being pushed into the pelvis. So it is compressed, yeah? Because the contractions are trying to push down the fetus. The fetal head is pushed into the pelvis and therefore it is compressed, yeah? So that is what early deceleration denotes. So that is expected, okay? Anything that is expected on Nclex is considered normal. It is expected. I mean, what do you expect when the contractions are there? We'll expect that the fetal head is going to be compressed because it's going to be pressed down. Yeah, because it's going to be pressed down. Therefore, that's not abnormal. Okay. So anyway, remember this. Look at the last point. It is good to be early. So just think about that. Even in this meeting, those that are coming late, those are late decelerations, which is bad manners. But those that came early, you're good people. So always remember this. It is good to be early. It is good to be early. So early decelerations are good. They don't need any interventions. Just document and continue to monitor. Yeah. So always remember that it is always good to be early. But when you late for meetings and everything, that's bad. So here we don't need any intervention. It's good. So what I wanted you to note here is how the maternal contractions affect, how does the fetal heart rate behave? It behaves in such a manner. So it's like a mirror, yeah? Give me, I give you. Do me, I do you. So don't forget, it's always good to be early. So early decelerations are good. Why? It means the head is being compressed, and that is expected with contractions. Okay, fine. So let's look at this now. Late deceleration. I've already said it is bad to be late. So this one here, we want to ask ourselves, why is the fetal heart rate being late? Why is there like a miscommunication between the contractions and the fetal heart rate? Something is wrong, okay? Something is wrong, severely wrong. So we have to correct these bad manners here. Why should the baby be late? Why should the baby's heart rate be late? So we have to correct this, okay? So this one for sure needs intervention. This one for sure needs intervention. So notice the behavior here, notice how they're behaving. So what does that mean? The baby's heart rate goes down long after the beginning of the mother's contraction and it recovers way after there's no proper communication like what you are saying here. Are you seeing the difference? So this is late deceleration. So late deceleration means placental insufficiency. The placenta cannot supply enough oxygen, cannot supply enough nutrients, cannot supply enough blood. So that is why it's like the baby is being suffocated, okay? I'll give you an acronym to remember all those things, so you don't need to kill yourself over that. But I want you to know that late deceleration is bad. So it's always bad to be late. It's bad to be late. It's good to be early, no intervention. So here, what are you supposed to do? Now that we have uteroplacental insufficiency, lower the head of the bed. Why? We want to increase blood flow to the mother, to the mother. Remember, there is also oxygen deprivation. So we want to enhance circulation. We want to enhance circulation of blood. Circulation of blood means circulation of oxygen, okay? All right. Then turn the mother to the side. Very important. Turn the mother to the side. Why? We want to relieve the pressure from the vena cava so that we have circulation of blood. Because remember, the weight of the uterus, it compresses the vena cava and thus preventing venous return. So we want to turn the mother to the left. And I want to be clear here. Listen good. On Nclex, if there is anything like turn the mother, even if it is to the right, as long as it is turning the mother, that is still okay. Okay? So it is not always that turn the mother. And when you see that there is an answer like turn the mother to the right, no, it's not always the right. Fine. If you are given two answers, turn the mother to the right, and then another answer, turn the mother to the left, always choose the left because we know the position of the uterus of a pregnant woman. It is the uterus normally anatomically, the position of the uterus is anteverted, anteflexed. That's what we say. The position of the uterus, anatomically, it is anteverted, anteflexed, and it is more inclined to the right. But if it is to turn to the side, whether it is the right side, the left side, is still acceptable on Nclex. But if you have those two positions, I will favor turn to the left. So turn the mother to her side, that is to relieve the pressure. Then if there was oxytocin infusing, stop it because you know oxytocin, it will augment labor and make the contractions worse. And remember, with every contraction, there is a reduced maternal blood supply. So stop stimulating those contractions and then administer oxygen. Why are you administering oxygen? Because the problem we are having here is uteroplacental insufficiency. So give oxygen. And guys, I want you to note this. Let Nclex not trick you. Look at the amount of oxygen we are giving. It is not 2 liters that we give patients that are having COPD. It's not 4 liters that we are giving patients that are having asthma. We are giving high flow oxygen, 6 to 10 liters. That is not just normal amount of oxygen. Yeah. So look at that. And then IV access, of course, notify the doctor. Notify the doctor. So here, in simple terms, we have to intervene. Now, another one here. This is what we call variable decelerations. Variable decelerations. Now, I've seen very many students confusing between variable decelerations and variability. Variability is good. Of course, we say moderate, variability is good. So variability is different from variable deceleration. So this means that it's a combination. We are having decelerations, but they are variable. Okay. So I don't know whether I'm making sense. The reason why I'm saying that variability is okay, when you plot the fetal heart rate, you realize that it is a curve, up, down, up, down. It's never a straight line. When it is a straight line, we are having issues there. There's an ominous sign. It means that maybe the baby's nervous system is not okay. So normally we should have something like smooth curve, up, down, up, down, up, down, okay? That is the normal. So that is what we call variability. It is never supposed to be a straight line. Now, in this case, variable deceleration, we have very serious decels. So the memory trick here is, remember the V's, like you can see what is happening here. The deceleration is not like a smooth curve, it's a deep V. Look at this one, it's a deep V. So always use that memory trick to remember this. It's a deep V. So this is again is abnormal. What does it mean? That the umbilical cord was compressed totally and there was zero blood that was passing through it. That's why we're having a very sharp V. That's why we're having a very sharp V. Okay. So again, do we need? Yes, we need intervention here. How do we do? Turn the mother to the side, stop oxytocin, administer oxygen, notify the doctor. Okay. The interventions here are the same interventions for the late deceleration. Now, the beauty with this fetal heart rate is that the interventions, those that need intervention, the interventions are the same. Okay. That is how easy it is here. Those that need intervention, the interventions will always be the same. So the variability I was talking about, variability okay? Yes, it's okay. So variability has to do with how the fetal heart rate fluctuates. A normal fluctuation is approximately 6 to 25 beats per minute around the baseline. So variability indicates that the fetus has a healthy nervous system. So it's never supposed to be a straight line when you plot the fetal heart rate. We need to have that variability, okay? Yes, so variability is okay. Now, in summary, this is what we are talking about here. So I want to compare the fetal heart, the maternal contraction down here, and with all those things. So we start with acceleration. See what is happening. When the maternal contraction begins to peak, what happens to the heart rate? It accelerates. That is so sweet, okay? It means that this baby cannot, there's no any pressure that can bring this baby down, okay? So that's what it means. When the maternal contraction, we're having the maternal contraction rising, the fetal heart rate also begins to peak. That is acceleration. So do we need to intervene in accelerations? No, it is okay. Early decelerations, remember we say that it mirrors the maternal contractions. So you can see it's like a straight, when you draw, it's like a straight line. It mirrors, it's like a mirror. It's like a mirror. So do we need any intervention? What was the memory trick? It's always good to be early. Yeah, always good to be early. So we don't have any problem. We are good. Okay. Variable decelerations. Variable decelerations. Yes, that one is bad now. Because remember those V, the sharp V's, it means that the blood pressure, it means that the umbilical cord is compressed fully, such that there is no blood flow at all. Okay, so think about the deep V's. Okay, that's how you can remember variable deceleration. And then late deceleration, the fetal heart rate, drops way after the maternal contraction. It comes late. And again, the memory trick, it's always bad to be late. So that one needs intervention. So in a nutshell, the first two, we don't need any intervention. You just document and continue to monitor. The second two, the last two, those ones need interventions. And the beauty is that the intervention is the same. Turn the mother to the side. Give oxygen, 6 liters to 10 liters, okay? Stop oxytocin, notify the doctor. So we can always use this acronym, LION, to remember those two that need intervention. So LION, okay? So think about the LION. So L stands left lying. So let the mother turn to the side. Basically, that's what we're saying. Which side is preferred mostly? Left lying. Don't forget, if there is right lying and that is the only turning point, that is okay. Pick that answer. Then give IV fluids, of course. Give oxygen or stop oxytocin. Discontinue oxytocin. And then notify the provider, because maybe emergency CS can be recommended. So don't forget, these are very huge tip here to remember. LION, okay? Now, the interventions, what I was telling you, we're going to use, I'm sure you must have come across this acronym, we call it VIL CHOP, VIL CHOP, VIL CHOP, VIL CHOP. So V stands for variable deceleration. What is the problem in variable deceleration? It means C. It means what? Cord compression. The umbilical cord is compressed. Yeah, that's how they correspond. So variable decelerations means umbilical cord compressed. E stands for early decelerations. Early decelerations, what did we say? Head compression. So the head is compressed. Is it expected? Of course, we expect the head to be compressed as it is being forced into the pelvis. So it's okay to be early. It's good to be early. We don't need to do anything there. A stands for accelerations. What did we say? Accelerations means oxygenation, or simply means okay. Accelerations means okay. So you don't need to do anything there. L stands for late decelerations, which corresponds to what? Placental insufficiency. Placental insufficiency. So the ones in red need interventions. The ones in, I don't know which color is that, is it purple or what? They don't need any intervention. We are good there. So where do we need intervention? Variable, the deep V's and the L. So what is the intervention? LION. Okay, that's the intervention that we need there. Fine. Let's attempt a few questions here, and let me change the settings here. You can type your answer and nobody else will see your answer apart from the host and the co-host. So just type your answer. It's now private at this point. What do you think is the answer here? Let's take the shortest time possible to answer, maybe 30 seconds to answer, because this is a very easy question. I want to see if you're following. What do you think is the answer here? So let's see. Fetal well-being during labor is assessed by A, the response of the fetal heart rate to uterine contraction, maternal pain control. So does it mean that when the mother is not in pain, the fetus is okay? Does it mean so? Accelerations in the fetal heart rate. It's not only accelerations. Remember, I also said that early decelerations are also good. So that answer is biased. that answer is biased. It is not only accelerations, even early deceleration. D, a fetal heart rate above 110. It should be above 120. So what is the correct answer? The correct answer here is A, during labor. Read the question again, fetal well-being during labor. During labor, the most important factor there are contractions. So we want to see how is the baby behaving when the contractions are there. Are we having late deceleration with the contractions? Are we having? So the response of the fetal heart rate to uterine contractions. And again, let me give you the strategy that we are using here. The strategy we are using here is that when you are given a question like this and you have no idea, look at the answers and choose the umbrella answer, the umbrella choice. An umbrella choice means that it is a choice that accommodates the rest of the answer. So when we say the fetal heart rate response, that one covers D. It also covers AC. Okay, so, but when we choose like accelerations, the fetal heart rate, isn't that a response? When we choose fetal heart rate above 110, isn't that a response? It's a response. So therefore, let's pick the umbrella choice. So the answer here is A. Let's try another one. What about this one? Please type in your answers. Just type in your answers. Nobody else is going to see your answers. So don't fear, don't fear. Nobody is going to see what you're typing. It's only me that can see and I will not share. So just type your answer really quick. So because of time, let's see. The nurse is caring for a multigravida client in active labor when the nurse detects variable fetal heart deceleration, variable deceleration on the electronic monitor. The nurse interprets this as the compression of which structure? So guys, what are we going to use here? So straight away we go to VILCHOP. So remember this acronym? This acronym is the game changer here. Anytime we are talking about fetal well-being, never forget VILCHOP. So what are we talking about? Variable deceleration. So which structure is being compressed? Variable deceleration. It is cord. So the cord is being compressed here. So the answer is what? C, umbilical cord. So you see how VILCHOP can help you? Okay, try this one. What do you think is the answer here now? But nobody's typing the answers. I want to believe that the questions are too simple and too easy. So you see that I don't need to waste my energy here. I don't need to waste my intelligence here. And this is how Nclex is anyway. So the questions you're seeing here, they are Nclex-like questions. So if you see them to be very easy, that is how Nclex looks. And if they seem to be so scary and so tough, I don't know what we can do to you, because this is how basically Nclex is gonna look like. Okay, so type in your answers. Thank you those that are already typing in. Well, let's take it. The nurses caring for laboring women should understand that early decelerations are caused by what? Early decelerations are caused by what? Accelerations as when the head is being compressed. So what causes that? Yeah, not umbilical cord compression, not uteroplacental insufficiency. It is compression of the head. So we can eliminate B, because B, umbilical cord compression, that would be variable decelerations. Uteroplacental insufficiency, that will mean the Virchow late decelerations, LP. Okay, spontaneous rupture of membranes, it has nothing to do. So we can eliminate B, we can eliminate C. So you remain with, maybe you begin with A and D. So what do you think should be the answer here? Anytime we're talking about spontaneous rupture of membranes, that's okay, that's good. Membranes are never supposed to be ruptured artificially. They're supposed to rupture spontaneously. So it's good when we have spontaneous rupture of membranes, when we expect the mother to deliver after the membranes have ruptured. So if they rupture spontaneously, good deal. So the answer here is A. Okay. Yes. Take this one. What do you think is the answer here? We are moving on.
Wewe ukuli eh? Ngala, kwani ukuli wewe? Kwani uko wapi?
Okay, so as customer. So as somebody is being encouraged to eat, let's look at this question. And I hope that guy is now eating. A multigravida in active labor is 7 centimeters dilated. That's almost full. The fetal heart rate baseline is 130. That is normal with moderate variability. Moderate variability, we say that variability is okay, not variable decelerations. Okay, so differentiate between the two. The client begins to have variable decelerations. Remember, Virchow. V corresponds to C, which means variable deceleration means cord compression. What should the nurse do? Guys, you remember, perform vaginal examination, notify the HCP. Of course, we're going to notify, but that is not the priority. That is not the priority. Reposition the client and continue to evaluate fetal heart rate or administer oxygen. So what are we using here? I gave you another acronym. You remember the lion? Remember the lion? So reposition, give IV fluids, give oxygen. You can see we are notifying the provider as the last option. So that is what we call prioritization. Okay. Of course, here you can see how many answers are we having. You can also go ahead and perform vaginal examination. Maybe we are having cord prolapse. Okay, so that can be a potential answer. Administer oxygen. Of course, we will administer oxygen. But you see, the prioritization. So what is the next thing to do? That is now where that acronym comes in. And that's why I told you that Nclex is a very cheap exam, only that it has its own way of how it answers the question answer. Now, in our classes, I tackle very well how to prioritize. So prioritization, I teach more about prioritization techniques, how to prioritize, and which are the strategies to use in prioritization. That exam is 70% prioritization, because they want to see, are you able to prioritize what and what? Because here we're having so many potential answers. So which one comes next? Okay, so here the answer is, immediately after you notice that, the next thing you should do is remember lion, so reposition. What about this one here? Again here, a nurse notices repetitive late deceleration on the fetal heart monitor. The best initial action the nurse should do is what? Again, remember, Late decelerations. So we say that it is bad manners to be late. So late decelerations means you need to intervene. So what is the intervention? Lion. So which one corresponds to lion? D, reposition the client, apply oxygen and give IV fluids. See? So you can see those acronyms. If you get to know those two acronyms here, I mean, there's no any question that in fetal heart and labor that will ever challenge you. Good to go. So you remember Vilchop. How do we correct the Vilchop? Lion. What about this one here? The nurse assesses a primary client with ruptured membranes in labor for 20 hours. Oh, that's prolonged rupture of membranes. And what is our concern with that? Infection. When the membranes rupture for so long, infection. And remember, on Nclex, infection is a topmost priority. The nurse identifies late deceleration. Now you see again, when you continue reading, the question changes. The first statement when you read, it was speaking about early rupture of membranes. Now, when you continue reading, it has shifted to another thing. Now we are talking about late deceleration, okay? So which interventions should the nurse perform? Late decelerations. Remember, what are the interventions for late decelerations? Lion. A, administer oxygen. Yes, you remember the amount of oxygen that we administer? 6 liters to 10 liters. So A is correct. These are select all that applies. It means we are having more than one answer. It's possible that we could be having more than one answer. So A is correct. What of B? Question the client about the effectiveness of pain relief. We're not talking about pain relief here. We're talking about late deceleration, the fetal heart rate. So how is that connected? Fetal heart rate deceleration and the maternal pain. So B is not appropriate here. Look at C. Place the client on her side. That is the first thing that we're supposed to do. So C is good, we pick it. D, readjust the monitor to a more comfortable position. I know if you read this very, very hastily, you must have read it as readjust the mother. We're not talking about the mother, it is readjust the monitor. So what has the monitor to do that you place the monitor to be comfortable? So after the monitor is comfortable, did the monitor complain? And let me tell you a hint on Nclex, anytime you're having a problem, prioritize the client and not the machine. Even if it is a ventilator, it's going off, the alarm is going off, don't assess the machine. Always assess the patient first. So the priority is the patient. These are the machines, I don't know what. It's after the patient has been stabilized. So we have nothing to do with the monitor here. Okay, even if it is comfortable, how do you tell that the monitor is comfortable? So D is ridiculous. E, apply an internal fetal monitor. Yes, we want to see those decelerations and everything. So what is the answer? A, C, E. Are we almost done? I'm sure we're almost done. A multi-client in labor at 38 weeks gestation has been diagnosed with Resa's sensitization and a probable fetal hydrops and anemia. Which fetal heart rate pattern the nurse find is most concerning? Now, that is a very bad type of fetal heart rate when we're talking about Resa's sensitization and the fetal hydrops. That means that there is Resa's isoimmunization and now there is a reaction. So that one always is a bad pattern. And we're also talking of anemia. So that is not even early deceleration. We have another terrible pattern that we call sinusoidal pattern. So go read more about sinusoidal pattern. It's a pattern that tells you that things are not good. The baby's spine is not okay. The baby, it's just, we call it an ominous sign. It's not a good sign. So sinusoidal pattern is not a good one. Okay, so it's better than everything else here. So really, hydrops fetalis, anemia, you know that. Yeah, so the answer is a sinusoidal pattern. We're saying that sinusoidal pattern is an ominous sign that reflects an absence of autonomic nervous control over the fetal heart rate, resulting from severe hypoxia. Okay, they're very rare and they are very highly associated with Resa's sensitization and fetal hydrops and anemia. So those are the defining features of sinusoidal pattern. Anytime they mention sinusoidal pattern, there must be at least two of these three: Resa's sensitization, fetal hydrops, or we call it hydrops fetalis, that kind of stuff. We should be winding up. This lesson is supposed to go for how many? Just 1 hour. So the nurse is caring for a laboring woman, is aware that maternal cardiac output can be increased by maternal cardiac output can be increased by, yeah, a change in position. Do you think when we change the positions, why do we change the position? So that there is venous return. That sounds to be a good answer. Let's keep it. Anyway, let's continue with the rest of the answers and see, because we are using the elimination method. B, oxytocin administration. Now, oxytocin, remember, with every contraction, there's fetal blood supply. Now that we are not talking about the fetus here, we're talking about the mother. Remember also, with every contraction, there is maternal exhaustion. Does that increase blood supply or decrease? C, regional anesthesia. Now, regional anesthesia blocks that particular region. It has nothing to do with cardiac output. In fact, anesthesia, it drops the fetal, it drops blood pressure. And remember, reduced blood pressure means reduced oxygen supply. Reduced cardiac output means reduced oxygen output. That's what it means. Okay, so intravenous analgesic, what is the difference between intravenous analgesic and the regional anesthesia? Okay, and on Nclex, this is the rule of the thumb. We say that when two answers are similar, when two answers are the same, or when two answers are alike, they can never be answers. So eliminate both of them. Okay. On the contrary, when you have two answers that are opposing one another, pick one of them must be the answer. When two answers are opposing one another, one of them must be the answer. So here, C and D are related. So if you choose C, why will you leave out D? Or if you choose D, why will you leave out C? So if they are alike, they can never be the answer. So throw them out, both of them. So the answer here is what? A, change in position. It enhances venous return. Which fetal heart rate finding will concern the nurse during labor? So we are looking for an abnormal one, which will concern the nurse. A, acceleration. Accelerations are good. B, early decelerations. Early decelerations are good. It is always good to be early. Okay, so that one won't concern. An average fetal heart rate of 126. That's the normal. It's 126 to 160. It's 120 to 160. D, late deceleration. That was very direct, wasn't it? Yes, late deceleration. It's always bad to be late. So you can see how easy these things are. Okay, so the answer is D. That one will concern the nurse most, because the nurse has to intervene here. Late decelerations means placental insufficiency. So always use the acronym VIL-CHIP, VIL-CHIP. Okay. All right, so that is it, guys. That's how we wrap it up, and thank you for your time. Now I open this session for Q&A. If you have any question, for more information, we always have these sessions on and off, so sometimes we give them. So anytime you see our advert that there will be this and you're interested, feel free to join. And if you could be interested to join our classes, we have intakes. The March intake is happening on 10th, if I'm not wrong. We have every month we have intakes, and we are becoming a big family. We've been doing this since 2020, and therefore I must say that by God's grace, we have been part of very many people's journey to the US, and we count a lot of successes, and that is what has kept us moving. Okay, if you are pursuing this, I want to encourage you this. It's doable. Don't give up. If you have any challenges, please feel free to always reach out. We are not so selfish with our information. Okay, always feel free to reach out. If you have anybody who is wondering where they could get assistance with training and coaching and mentorship, please, you can only do us one favor, recommend Apply International. And as always, Apply International, we strive to give our best and we never disappoint. Okay, so if you could be having somebody or even yourself and you are interested, you may want mentorship. You know, I always tell people that we are not mentoring, we are not coaching, we are not helping nurses because they are stupid or because they cannot do it. I mean, you can read and understand, but sometimes you need some guidance. Okay, this is how the question is framed, and this is how you're supposed to answer. You remember those strategies I was telling you? When two answers are same, eliminate both of them. When two answers are, you know, those strategies, and very many more strategies. Prioritization, how do we do that? So you can find somebody to guide. And number two, sometimes you need motivation, somebody to tell you, hey man, you know what? You need to wake up and read. You know, the exam is just around the corner. So you need sometimes that person to always put you on toes. And that is part of our mandate that we do. Once you sign an agreement with us, it will be our work to know and tell you that, hey, you're having a Q bank and today you've not done 50 questions. You need to do 50 questions. Yeah. Okay. Right. So I think mine ends there. And if there is anything, please let me know. You can unmute yourself and ask, or you can type, drop a comment in the chat box. We will always attend to them all. Otherwise, thank you so much. And before I wind it up, there is a hand that is up. I can see Diana Milimo. Is your hand up? If your hand is up, you can proceed. Is it a question or what? Diana, please go on.
Yes, it is a question. I wanted to ask, at what point do we say this is fetal distress? Is it when it is variable deceleration and late deceleration, or it's only when the fetal heart rate is above 160? During this whole process, at what point is it fetal distress? Thank you.
Right, I don't know. Do we have anybody in the group that will want to attempt to answer that question before I weigh in? And by the way, I want to tell you that my area of specialization is reproductive health. That's what we call it in Kenya. But here in the US, it is called here you become reproductive is so general. So can anybody try to answer that question? When do we say that this is fetal distress? Is it when the heart rate is way high above, or when we are having late decelerations? What? I think that was the question if I try to understand it. Okay, fine. Let me try to answer our good lady that has asked that question. Now, the pattern for fetal distress always will be this. The fetal heart rate will shoot, and then it reaches a point, it goes out the grid, the normal 120 to 100. So it goes up, above 160. And then it will start coming down. And the point it starts to come down, if you don't intervene really quick, that baby will die, because when it starts to come down, it will go down until it goes to zero. So that is always the pattern. So anytime you see it accelerating beyond, remember the acceleration we're talking about here is the increase from the baseline, but still within the normal. So the moment it goes high, that is the first step. That's the first indication of fetal distress is setting in. So it will shoot above and then start coming down. So therefore, at what point do we say that now we are having fetal distress? When we are having variable decelerations and late decelerations. So those decelerations that we need to intervene. Of course, the fetus is already now getting distressed. So you can say that the fetus is distressed when the fetal heart rate is 100 and when it is peaking, when it is accelerating. So that is just but the precedence. So once it accelerates and reaches peak and begins to drop, now we have a real problem. We have a real problem. So those two, late decelerations and variable decelerations, those ones will tell you that for sure, we are having an actual problem, not a potential problem. When it is accelerating beyond the normal, that is a potential problem. And that is where you need to intervene before it begins to decelerate. And that's what I started by saying. As a nurse, Nclex is to see whether you are able to find out a potential problem and prevent a complication. Okay, I hope I have tried to answer. I don't know whether I've answered you. You can let me know if you got your answer.
Yes, I got the answer. Thank you so much.
You are most welcome. Thank you. Yes, Victor Sunday, I see your hand is up, sir. Is it a question or a comment or something? Please go on.
Thank you. It's a question, not pertaining to what has been discussed, but I want to find out if you have this recorded videos on the YouTube channel where I can go and find it.
Victor, I bet I haven't heard exactly what you, I don't know whether there's anybody who has heard what you said, whether it's me who is losing you, but I think, will you maybe take the question one more time, please, if you don't mind?
Yes, please. Please, can you hear me louder?
Yeah, I can hear you, but seems to be some background noise. Maybe give it a try. Let's see if I can get it.
Hello.
Yes.
Hello, please. Is it better?
Yes,
Sorry,
Victor,
please,
go
just a
on, go
second.
on.
Okay. Yeah, so I want to find out if you have these lessons on your YouTube channel where someone can go and reassess things.
Oh yeah, we have a YouTube channel, but YouTube, because we have a lot and a lot, because we have lessons almost like we have our main lessons every 3 days a week. That is Tuesday, Thursday, and Sunday. So we cannot be loading everything on YouTube. In our YouTube channel, they are just short skits, something like that. But we have our platform, our portal. So that is where we put everything there and organize and put everything in our learning, in our e-portal. Yeah. And okay, so that is what we have our very elaborate portal that happens. So maybe Mr. Dennis, you can answer that more vividly.
Okay, but how can we access the portal? Does it need a registration or something?
All right, let
Thank you
me
so much.
rope in our director for the e-learning portal and so on, and the registrations or what have you. Please, Mr. Dennis, if you can hear me, please, will you be able to respond to that question?
Yes, thank you, Mr. Chacha. Kindly confirm that I'm loud and clear.
Personally, I can hear you loud and clear.
Okay, hope you are able to see my shared screen. Victor, considering on the question of the class recording, yes, we have an e-learning portal where all the classes are always recorded, including this free lesson today. It's going to be recorded and updated in our e-learning portal. It's a very well elaborated and easy to understand and navigate e-learning portal for classes, question bank, and also materials. So kindly confirm that you are able to see my shared screen. So I have shared our e-learning portal. You can see the materials inclusive with live online classes, of course, and this is what to expect in our e-learning portal. We have divided the entire Nclex, what you're supposed to learn into modules, and inside these modules we have lessons. And in addition to that, we usually have topic reviews, and we always upload them in our e-learning portal. So even if you join, those who are planning to join our March intake, you're going to get access to the previous class recording together with the class recording that you are going to hold. I hope I've answered that. So in the YouTube, we don't upload our classes. This class recording are only those people who have subscribed are able to get this feature. Thank you.
Right,
Okay,
thank you, sir,
well,
for that. I hope, Victor, you got. I hope you got an answer.
yes, please.
Great, thank you. I'm happy.
Okay, thank you so much. Before we continue with the Q&A, I just want to take you through a short presentation regarding Apply International and what we do. So let me share the screen. Yes, I'm sharing it. Okay, there it is. Mr. Chacha, you can assist me with admitting. I can see that people are joining. Kindly help me with admitting them. Okay, so basically, I just want to take you through a short presentation of about what Apply International entails and what we do. Basically, what we aim is giving you connection with either job opportunities and also ensuring that you find it easy, especially nurses who want to do Nclex as self-sponsored candidates. Majorly, we deal with self-sponsored candidates because we understand that the people who want to self-sponsor themselves for the Nclex, then we link you with a direct hiring agency. And of course, we're going to share to you more on the advantage of doing Nclex as a self-sponsored candidate vis-a-vis being sponsored for Nclex. So because of time, I'm just not going to take you through what we do. But basically, just want to tell you that Apply International is a registered company. You can go and check it online and confirm, especially those who are from Kenya. It was incorporated in May 2020 to help clients with international job application and registrations. Our mission, I'm not going to take you through this because of time, but I just want to briefly tell you about the services we do offer. One of the services that we do offer and which we shed light more today is the Nclex RN division classes. As we have told you, our classes are starting on March 10th. So if you're planning to join our classes, ensure that you reach out. I'm going to share our contact. You can reach out, then you can pay for the classes. Remember, our classes are 4 months. I'm going to talk more about what they entail. We also help with the entire Nclex registrations. So if you are wondering where to start to register for Nclex, one thing you need to know, you just don't go and pay for Nclex and go and sit. There's some steps that you need to do. One is for an international nurse, you need to do a credential evaluation service, basically with CGFNS or GSA. We will advise you more about that. Then you also need to register with the Board of Nursing. We also need to do security background check. We'll give you the fingerprint cards if you need them, you have them. We also assist with booking for Pearson View. Pearson View is the body that administers Nclex exam. We are lucky, those who are around East Africa, there's an examination center that was opened in Nairobi, Kenya. So if you're around East Africa and West Africa, also the clients from North Africa, I think Nairobi is the closest center because we have only 2 centers in Africa. We also train for English proficiency exam, that is IELTS and OET. Our classes are for 6 weeks, individualized. You need to know that our classes are individualized because we understand the needs of IELTS and OET, so that we can do a lot of stimulation and a lot of mock tests so that you can be ready for the exam. We also, for those people, if you pass Nclex, you're looking for a job. Remember, I told you we help linking those people who have passed Nclex with the job opportunity, especially direct hiring organization, that is direct hiring agents, so that you can be able to work in the US. So we are able to prepare for you an international CV alignment. Remember, it is ATS compliant and ensure that they contain those keywords which are necessary for you, for your CV to stand out. We also help with visa application services, also We also help those, especially if you're a nurse and you have a degree, probably you're looking for you want to enroll in an university in US, Australia, or UK. You can always reach out to us. We can help you with the applications. Yeah, you can talk about scholarship. Yes, you can always reach out to us. In time and again, we always have scholarships, so we can always advise you on that. We also assist with accommodations, flight booking, and taxi services to and from the airport. Yeah, so if you're planning to test your exam in Nairobi, Kenya, we have a very good Airbnb. I'm just going to give you a slight overview of what our Airbnb entails. So I'm just going to, for a slight moment, I want you to have a look at this. So that is what it's an overview of one of accommodation near the exam center. Yes, so you can see what it entails. Okay, so because of time, I'm not going to take you through all that. So let us just point it there regarding our services. So if you need any of these services, feel free to reach out to us. So I'll write this number down. You can WhatsApp us or call us. Our number is 254-706-922-179. So if you are interested in one of these services, always feel free to reach out to us. Yeah, so I had talked about the Nclex registration services. This is just an overview of what you need to do for you to do Nclex exam. This is an overview of the Nclex registration process. Yes, so as I've told you, our next intake, remember today was a free class, and that was just a taste of what our tutors do regarding the Nclex training. So our next class is starting March 10th, 2025. So if you are interested, feel free to reach out. What does it entail? Live Zoom classes. Remember, our classes are via Zoom on Tuesday, Thursday, and Sunday, 7 p.m. East African time. Then in weekdays, we usually have a live topic review sessions at 5:30 a.m. or sometimes at 8:30 p.m. Then, of course, you're going to get exclusive. You're going to get inclusive access to the e-learning portal or the class recording. Additional materials are there, and also the tutors over time, they usually post Nclex type question. And also during the topic reviews, you are able to go through the Nclex style questions. And in addition to that, we usually ensure that once you have gotten your ATT, we do something called individualized assessment, where the tutor at least have an individual session with you to monitor you. So we usually strive to ensure that we provide a service approach to individuals so that at least we are able to meet every need of a client. And also we are open to feedback to ensure that our services add value so that at least you get value for your money. Yeah, thank you. I think I will basically open the session for Q&A. I think Mr. Chacha, you can take it from there. Thank you.
All right, thank you, sir, for that very brief and very vivid description of what we do and what we are. I know there could be many questions, and at this point, we will just hang around for some few minutes. If you have any questions, you can just drop in a text if you don't want to ask it in public. You can also raise up your hand, or you can just unmute, and we give you an opportunity to ask regarding what we have said today, regarding anything Nclex. Yeah, anything Nclex, and whether the process, anything Nclex, whether the job market, because I'm talking, I told you that right now, as I'm speaking, I'm from the US and practicing, not just sitting in the house, practicing as a nurse, okay? So perhaps you could be there and having a question. And I am the team leader for the tutors in Apply International. Yeah, so I'm the director, classes, and so on. So we have a very vibrant team, a very dedicated team of tutors that will always touch, and impact you in a special way. I know you could be in another forum. I'm not saying your forum is bad. In fact, your forum is best. Only that we are best and unique in our own different ways, okay? So I'm still making this clarion call that if you know there's somebody who really needs some help and some assistance and they can't get it anywhere, just don't think far. We are right here and more than willing to assist. Okay. Please, if you have any questions so that I don't keep on talking. You know, I'm just talking so that if there's any question, somebody can ask. So is anyone having any question, any general question as far as Apply International is concerned, as far as Nclex is concerned, anything that is not clear, whether the process, we should be able to answer all your questions to the best of our knowledge. Okay, feel most welcome.
Yes, there's somebody who is asking on YouTube how much we charge for our classes. I just want to clarify that. Yes, our classes goes for $200 or Kenya shillings 25,000 for 4 months. In 4 months, you'll be able to cover the whole Nclex division package that we have prepared for you. And remember, I've just said our classes are starting on March 10th. On 10th, we're having an orientation session. So if you're interested, feel free to reach out to us. Thank you.
All right, thanks for that. Any other question? Yes, Diana, please go ahead.
Okay. Yes, I wanted to find out when learning NCLEX and preparing for the exams, is it a must that you need a laptop rather than a tablet or a phone so that you learn the certain skills of answering? Maybe there is the methods of the questions, matching, dragging, and all. Is it a must that you need to have a laptop? Okay.
Well,
Thank you.
then I think our platform has been simplified to the extent that all you need is just a smart gadget. Even your smartphone, the Android smartphone, and it's not a must that it has to be an iPhone. Yeah, you just need a smart gadget like a phone, a tablet, you're good to go. It must not just be a laptop.
Okay, because you can, I don't know if there are questions during the exam which has drag and drop, left click, right click. Can't that
Yeah, of
affect
course,
the way
we
you
look at
answer?
all, we look at all those questions and the possibilities. And maybe what might be slightly different is how we frame that question and how we guide students to answer it. So yeah, we are very accommodative so that you really don't have to get a very sophisticated gadget for you to access or for you to answer those questions. So you can answer any question using your simple smartphone.
Okay, thank you.
Yes, you're welcome. All right, to this end, I want to believe that there's no more question. And ladies and gentlemen, it was an honor to have you all. And thank you for the interactive sessions that we've had. Maybe the time was not, you see, we tried to rush. If there is any question that you could be having, always feel free to reach out. The contacts are right here. You can always reach out anytime, drop a text, you can do a call, and we will be able to address all your concerns. Otherwise, I appreciate all of you. I wish you success. Guys, I share in your dedication and commitment. I know Nclex is very demanding. Those that are planning to do Nclex, it's very demanding in terms of time, in terms of resources. We always pray that God gives you good health. Yeah. Remember, if you feel like you are overwhelmed, you can always reach out and we can help where we can. Thank you. Wish you the best. See you next time. Okay. Don't forget, if you like what we are doing, don't forget to recommend 1 or 2 people. So tell a friend to tell a friend. Yeah. Thank you. Right, Mr. Dennis, I think you can